Good day. I'm Dr. Michael Aziken of the Department of Obstetrics and Gynecology, University of Benin Teaching Hospital, Benin City, Nigeria. I'm presenting shared genes, shared disease, genetically linked endometriosis with mirrored clinical presentation and treatment outcome. This is my mentor, and these are my team members, who are all from the University of Benin Teaching Hospital. At this point, I would like to declare that I have no financial support to declare, and there's no conflict of interest to this presentation. Endometriosis is a chronic gynecological condition defined as the presence of functional endometrial glands and stroma outside of the uterine cavity. Now, despite the unclear etiology surrounding endometriosis, several theories have been proposed, and one of them is the genetic predisposition to endometriosis, which is typified in this case with where we have extrapelvic presentation in identical twin sisters. Extrapelvic presentation is quite uncommon, and even more uncommon is umbilical endometriosis. Now, that in all makes this case very, very special. 30-year-old identical twin sisters walked into the gynecological clinic complaining of cyclic pelvic pain, dysmenorrhea, and menorrhagia. Pain was severe enough to impair daily activities. They also complained of cyclical umbilical pain, swelling, hyperpigmentation, and occasional bleeding from the umbilicals during menstruation in both sisters. These sisters attained menarche at 13 and they noted dysmenorrhea at 16. This image is the image of twin one's umbilicals before surgery. They also developed umbilical symptoms at 26. Meaning, within just a few months apart of each other, they also developed ovarian endometriomas at different times, still within a short interval between each other. Twin 1 had a laparoscopic ovarian cystectomy, and twin 2 had ultrasound-guided ovarian cyst aspiration. This surgical approach caused transient symptomatic relief, and even at presentation or physical examination, nodules were palpated at the level of the umbilicals in both twins. Now, these sisters were placed on prolonged gonadotropin-releasing hormone agonist therapy, for which they experienced transient symptom relief, excluding the umbilical symptoms. They subsequently had the excision of umbilical nodules and umbilical reconstruction. The excised nodule was sent to the pathologist for histology, and a finding of endometriosis was confirmed. The sisters were placed on gonadotropin-releasing hormone agonist, continued after surgery, and for which they experienced total resolution of symptoms, and they are on it today, and they are very happy and they are very comfortable. This is an image of reconstructed umbilicals post-op. Now for the teaching points. This case supports the genetic theory of endometriosis as demonstrated by the rare occurrence of extrapelvic endometriosis, particularly umbilical endometriosis in identical twin sisters. It also highlights the need for a high index of suspicion in the face of for extrapelvic endometriosis when patients present with cyclical pain or bleeding from unusual sites. This case emphasizes the importance of detailed and focused history taking, especially when similar symptoms occur in the same family. Our experience also demonstrates the limitation of conservative surgical approaches alone, such as cystectomy or cyst aspiration, in achieving sustained symptom control. Medical management with gonadotropin-releasing hormone agonist therapy was effective in controlling most symptoms. Counseling, as well as peer support, played a huge role in encouraging adherence to prolonged therapy. Remember, they were sisters that were going to the clinics together and receiving this care together. Finally, this case underscores the importance of multidisciplinary care and person-centered care. Collaboration with the plastic surgery team was phenomenal in managing these umbilical lesions, pigmentation, achieving acceptable cosmetic and outcomes, and supporting the patient's psychological well-being. Also, it's very important to note as a take-home that this case highlights the value of multimodal treatment. It highlights the use of gonadotropin-releasing agonists and surgical excision of residual nodule, umbilical, and also umbilical reconstruction as effective management strategy when controlling symptoms long-term and ensuring physical and mental well-being, respectively. Multimodal treatment, multidisciplinary care, person-centered care, and peer support is justified and advocated as a means of ensuring good reproductive health. Thank you very much. These are my references. Thank you very much.